Okay. Okay then, children, welcome to the 5th session of this series, right? And today we are going to discuss on popular demand gestational diabetes. As you understand, if you are looking at obstetrics and the MBBS, one of the commonest topics is diabetes, and then the second commonest or equally common topic is pregnancy induced hypertension. So these are the two things that you really need to know very well. Okay, so that you have to understand. So the more you do these topics, the higher the chances that you will meet them in during exams, in your evaluations, in your papers, in your MCQs, because those are two very important topics. So of these, today I have chosen gestational diabetes. So let's talk about it. Now, let me pin my video. Right, okay. Fine. Now, if we look at gestational diabetes, right? Now, when you sit in your clinic, or there are different types of patients who are going to visit you with problems of diabetes. The first group that goes to come to you are the women who already have diabetes and that they know that they have diabetes, right? So it's a already diagnosed group of patients who have become pregnant and is coming to you for follow-up and treatment, right? So now this group is going to meet you all with diagnosis cards, with follow-up clinics in the endocrinology or with a physician or any diabetic clinic. They'll be on different kinds of medication, different kinds of oral hypoglycemics, different kinds of insulin, different regimes of insulin. So already they are getting or is being managed for diabetes. The second group who are coming to you are women who have diabetes, but they do not know they have diabetes and they have got pregnant. So this is a group which you must discover and find out whether they have diabetes. So they come to you unaware that they have diabetes. So that is the second group. Okay. The third group of women are the women who will come to you without diabetes. They get pregnant normal. However, they will develop diabetes along the way. Somewhere along the way, they will develop diabetes. These are what we call gestational diabetes. This is one part of gestational diabetes that you have to remember. So these are the three groups of women, if we are talking about glucose problems, who are going to meet you. In summary, number one is women who have pre-existing diabetes and they do know they are already diagnosed and on treatment on diabetes, right? Second group, women who develop diabetes along the way. Initially they didn't have it, later on they get it because of the pregnancy. The third group are women who are diabetic but have not been diagnosed and they do not know that they are diabetic. They get pregnant, then they come to you. And this is someone or these patients we need to diagnose them. So these are the three groups. Today, I'm going to speak only about gestational diabetes. I'm not going to speak about pre-existing diabetes, right? And I'm going to only talk to you about gestational diabetes. Is that clear? Right? So these are slightly different entities, but principally there are some similarities which you have to understand. Is that clear so far? Yeah, okay. So what is gestational diabetes? If you look at now, there are four things that come into play, children, for your MBBS and if the IC1 registrar, if there are postgraduates, there are four entities or four associations which you need to understand to think about diabetes, right? However, as a final MBBS student, you might not want to or have to look at these things. But one of the first things in Sri Lanka is that you need to look at the diabetic guidelines issued by the Sri Lanka College of Obstetricians and Gynecology. Right? That is number one. The number two document is there are FIGO guidelines, FIGO, Federation of the International Gynecologists and Obstetrics, FIGO guidelines, which gives certain kinds of guidelines and recommendations. The third one which you need to look at is the other NICE guidelines, NICE, right, which gives us guidelines as to what we need to follow and look at. So these are the three basic associations which we sort of look at guidelines for the management of our patients. The fourth thing which we need to look at, there is an international organization, right, which combines an international organization for the study groups in diabetes in pregnancy, right? It has a long name, IGSTCP, like that long name, but it's basically a collaboration of study groups, international collaboration of study groups who study diabetes, and they base their guidelines on various studies that have been done. And one of the main guidelines that most of the organizations have relied upon is the HAPO guidelines, which is called the Hyperglycemia and Pregnancy Outcome, which is a study which was done around in about 21,000 women. And some of the criteria in most of these associations are based on those HAPO study, okay, which is a 2008 freely available New England Journal of Medicine, which you can, if you want to look, please go and have a look. And the fourth organization that issues guidelines is the WHO, right, children? So all these guidelines, as a summary, I just want to tell you what, is always a summary, and the recommendations come from most of what is useful to us comes from these four associations. The guidelines and the information is totally free on the net, right? So if you want, please look at those. In summary again, what are these? NICE guidelines, Sri Lanka College of Obstetricians and Gynecologists. The NICE guidelines are collaborated with the Royal College of Obstetricians and Gynecologists. Then the Sri Lanka College of Obs and Gynae, then the FIGO guidelines, FIGO, right? And the fourth is the WHO, right? And these associations, these organizations will base their recommendations on some of the organizations, like the International Obstetrics, the collaborative study groups in hyperglycemia and pregnancy. Those will collaborate on some of these organizations and take their recommendations. And some of the recommendations are based on the HAPO guidelines, which is widely used, not HAPO guidelines, the HAPO study, which is widely used to code the norms for diabetic control, as well as the norms for cutoff marks in the oral glucose tolerance test, which we widely use. Is that clear? Right? So what I'm going to tell you all today is going to be a mixture of all these, right? I'm not going to specifically rely on one thing, right? So I'm going to talk to you about the current guideline or current practice which we have. So if you want specific information and to read about each of these, please go to each of these sites and download these documents and read them. After I have discussed the general guidelines with you, that would give you a very good idea of gestational diabetes as well as pre-existing diabetes, which is going to be another different class. Okay, is that clear? So now you all understand the base on which we are going to stand today, right? So we are going to talk about gestational diabetes, right? Number one, in gestational diabetes children, the first thing is we are going to talk about is what is the definition? The definition is, there are different definitions in basically, if diabetes or any sort of glucose intolerance is discovered in the first instance during pregnancy, it is going to call gestational diabetes. Gestational diabetes mellitus. Is that clear? Because it is discovered in pregnancy, it is going to be called gestational diabetes, right? What you have to understand is in this group, there are two kinds of women. The first kind of women are the women who already have diabetes, who have not been diagnosed, but comes into pregnancy, becomes pregnant, and then we discover diabetes in them, right? And the second kind are the women who do not have diabetes. They become pregnant, and then during the pregnancy, we discover diabetes. Both these are gestational diabetics by our definition, which I just told you. Is that clear? Whether where they got it from or whether it is actually pre-existing diabetes should not be a huge concern, because the pathway of treatment will remain the same. Okay, but there may be few exceptions. I will tell you as to what will. So the treatment will be slightly different in exceptional circumstances where the blood sugars may be extremely high, right? But however, usually the pathway remains the same. The second thing which you have to understand is that we can suspect in certain patients, yes, maybe this is pre-existing diabetes. Who are these? These are the women we diagnose diabetes in the first trimester and maybe in the second, but before 20 weeks. So if we arrive at a diagnosis of diabetes in a woman who is in the first, or let's say less than 20 weeks, the chances are that it did not develop immediately in pregnancy, but the chances are she had some form of glucose intolerance or diabetes pre-pregnancy. She never knew about it, but she became pregnant and we find it. Do you understand? So we can have a suspicion, but that makes no difference to our follow-up and treatment plan, okay? And how we manage her during the pregnancy. We can have a suspicion, but still the diagnosis will remain as gestational diabetes, right? But what you all can do and can say is that, okay, because this was diagnosed in the first trimester or before 20 weeks, there is a possibility that this might have been pre-existing diabetes, and we diagnose it now, right? And how do we find out whether it is actually pre-existing diabetes and she got pregnant? It's because after pregnancy, after 6 weeks of pregnancy, then we will do a glucose test, a diagnostic test for diabetes, because after 6 weeks in the post-delivery period, then she becomes, the pregnancy changes are gone. Then we perform a diabetic test, and if she is having diabetes, then we can look back and say, ah, yes, this is a woman who probably had diabetes and got pregnant. Do you all understand? So that is something that you need to think about. Okay. Now let us go back to, or go to a patient management with gestational diabetes, right? Okay. Now, when they come to us initially in the clinic, we have a chat with them, right? And then we say, okay, and we just look in the booking visit itself, right? We can do what we call clinical screening. Clinical screening in the sense we ask them several questions and find out, yes, is there a possibility that this woman may have a higher risk of having diabetes now? Remember that group? Unknown diabetes coming into it. Or is there a higher risk of these women developing diabetes in the future? So this is called clinical screening. It is not absolutely effective, but what are the questions that we ask? See, in a population, when we talk about screening children, what do? Simply said, screening is we take a population of women or whoever we are interested in, a cohort, and we divide them into two lots. One large lot would be screen positive people and the other is screen negative people. Screen positive means that group has a higher risk of having the problem. Screen negative is that group has a lower risk of having the problem. That does not mean that the lower risk group, there are no women not having the problem, right? But there may be a few. And in the group that we think that there is a higher risk, that does not mean all of them are having the problem. Do you understand? So a screening test is used just to divide the cohort into two groups, high risk and low risk. That's simply what is screening. Okay. So different screening tools can be used. And in this case, what I'm saying is, what I'm trying to tell you is, we can use clinical screening initially. And what are the questions that we have to ask? Remember, in Asian women, right, they are already high risk because Asian women are at a higher risk, and the black Caribbeans and Asians are at a higher risk of developing diabetes or having diabetes already or having gestational diabetes, number one. So being Asian is a risk factor already. Being pregnant is also a risk factor. Why? Because I have taught you before, I think, the placenta starts to produce human placental lactogen, and it increases with the gestational age. What does human placental lactogen do? It's a fetal hormone. It goes into the mother. And what is its purpose? Its purpose is to get glucose for the baby. And how does it do that? Number one, it antagonizes insulin, mother's insulin. It reduces mother's insulin production. It decreases glycogen formation. 3, it increases breakdown of glycogen from glycogen to glucose. It converts mother's metabolism from using glucose to using free fatty acids, right? So therefore, it goes into the mother and basically increases the mother's glucose but prevents her from using it. At that point, if the mother's pancreas cannot keep up with this HPL onslaught, right, then the woman develops a relative deficiency of insulin. For her, her pancreas is producing enough, but when it gets HPL into the system suddenly, then if the woman's pancreas cannot keep up with the amount of increased glucose, then she will get diabetes, or what we call gestational diabetes. Do you understand? So therefore, we might find risk factors in our clinical screening on. So what are these questions we need to ask? Number one, is she obese or overweight? Over 30 kilograms per meter squared or BMI is a risk factor. 2, did she have a very large baby earlier? Now in most ones, probably they say 4.5 kg, but probably for our babies, I think 3.4 kilograms is, I think, better than a 4.5 kilogram cutoff mark for macrosomia, because it is mostly due to the other countries, right? Our babies very rarely reach 4.55, but 3.5 or 4 kilogram baby, I think we should call it a screen positive thing. What is the third thing? Any first degree relative having gestational, having diabetes is a risk factor for that. Fourth thing is, if she has delivered earlier, whether she had diabetes before this, that is gestational diabetes in the previous pregnancy. Next is, if in the history, if she had a baby with fetal anomalies. Now there are very specific ones for diabetes, like sacral agenesis, which is very due to diabetes actually, not gestational diabetes. But if the baby had fetal anomalies, there is a possibility she might be already having diabetes now, right? So any anomaly, any intrauterine death, that also might, in the previous pregnancies, might tell us, okay, maybe she had diabetes then. Do you all understand? So these are the screening questions that we need to ask. And if this one of these screening factors are positive, then in your brain you need to think, okay, should we do a diagnostic test for this woman? Because that is simply screening by our questions, or it is called screening, clinical screening. Is that clear? So, or clinical screening by history. So that is number one. The second type, so now if the woman is Asian, which most of our women are, right? And if they are pregnant, is already two factors. So if another screening criteria adds up, then we already have three criteria. So probably in that woman, it might be safer or wiser for us to think of going directly for a diagnostic test after our clinical screening. Is that clear, children? Right? So what do? We screen clinically or by our history, divide them into two groups, high risk and low risk. And then for the high risk group, the intention, we do a diagnostic test or to confirm whether the problem is there. So in diabetes, when we are thinking about what is our diagnostic test, it is called the oral glucose tolerance test, right? Or OGTT, right? So that is universally accepted. So when the woman comes to us and after we ask the screening questions and we think, and she has become clinically or by our history positive, then we can perform an oral glucose tolerance test for that particular group of women. Is that clear? So that is one way of going about it. Then, if there are no problems in our history, then the second thing is in our battery of tests which we do, which I have discussed with you all. I have spoken to you about 8-9 tests. Remember in the obstetric history taking, as far as I remember, right? In that, what we do is now we will perform some form of screening test for diabetes, even if she's by history screen negative, right? So each unit, children, will choose their own screening test. Okay? So it will depend on the unit, it will depend on the hospital, it will depend on the consultant. So there is no specific screening test that is recommended. Anybody can choose anything. Okay? There is only one diagnostic test recommended, but the screening can be anything. What are these? You can have a urine dipstick +2, that becomes screen positive. Okay? You can do a random blood sugar. They come, we do. If the random blood sugar is over 140 milligrams a deciliter, that becomes screen positive. Okay? Then you can do a postprandial blood sugar. They eat and in 2 hours you take a blood. If the blood sugar that is over 140 milligrams per deciliter, in some units they will take 120 milligrams per deciliter. If then they will consider it as screen positive, right? Then you can do a HbA1c, and if it is high, some units might take it as screen positive. Then there's something called a time random blood sugar. That means she comes to the clinic, you take the blood and you ask her, okay, when did you last eat? Right? And then depending on the number of hours between her last meal and your blood test, there is a chart which says, okay, above this, it's going to be positive. You all understand? That is being said, that is called a timed random blood glucose, because women will come at various times. Sometimes they cannot come at different. So that is also there, right? Then there can be other ways. So fructose, I mean, is being used, not very useful. So these are all, remember children, a fasting blood sugar on its own can be used, right, as a screening test. So all these are single tests which is used at random by different units and consultants and hospitals, and depending on the practice, that are all these are screening tests and none of these are diagnostic. Is that clear? So if one of these screening tests, so by history is a screening test, anything, RBS, PPBS, FBC, urine dipstick, anything, all these are screening. If one of these becomes positive, then you have to proceed to a diagnostic test, which is called a oral glucose tolerance test. Is that clear? Right? So the booking visit will go on like that, right? And now, if there is no diagnosis, right, and if they are not screen positive, or if they are just screen negative, then our normal pregnancy follow-up will go on. Okay, so now we have gone past the booking visit, right? And if we diagnose diabetes at this point, that is in the booking visit, then in our brain, what will go on? Okay, probably this is pre-existing diabetes. But that doesn't matter, because then we have to follow our pathway of managing this woman. Is that clear? Right. So let me skip to 28 now, and then we will discuss the management plan as to what we do, because what we do at 28 is going to be the same as what we do at initial stages. So let's skip to 28. Now, as the pregnancy goes on, right, now she starts to become high risk for diabetes. Every pregnant woman between when they are approaching or passing 24 weeks becomes at risk for developing diabetes, right? Why? As I told you earlier, because the amount of human placental lactogen will go up, and it antagonizes the glucose control in the mother's body, and therefore she develops diabetes, right? And I told you why. And therefore, every pregnant woman, this is the recommendation, starting from 24 weeks to 28 weeks, that is the time they are at the highest risk for developing diabetes or gestational diabetes, and that is the best time for us to find out whether they have gestational diabetes. And therefore, what do? We perform universally for every woman a diagnostic test between 24 and 28 weeks. And what is the recommended diagnostic across the board, right? FIGO, NICE, our college, then and the WHO is the oral glucose tolerance test, right? Now here comes all the controversies, because the diagnostic test, the controversies are what? The cutoff marks. That is the problem, and that will remain a problem for a long time. Okay, until each country does its own very large study, which are going on in Sri Lanka also, I think, right? And then you do a population specific huge study, and then you develop your own criteria. The cutoff marks for these, it becomes hugely variable, children. Okay, so some units may use different kinds of oral glucose tolerance tests. Some units may use different cutoff marks. So as a guideline, what you all can do is to base your management on one type of cutoff mark, because otherwise it becomes confusing to practice. Okay, so now let's first of all look at the variation in the types of oral glucose tolerance tests that has been done. I forgot initially, remember, there's something called remember, sometimes you can give glucose, right? There's a screening test with glucose. I'm not talking about that at all, right? We are talking about a diagnostic test. So a screening test by giving glucose is one of the screening tests that is done in the booking visit or at the initial meeting. Is that clear? This is not what I'm talking about, the proper diagnostic test. Now, the diagnostic test for these, right, Now there are various kinds of oral glucose tolerance tests, and there are various values for them. What are these types? The commonest type which we use, which I also personally use, is the 75-gram oral glucose tolerance test. Now, how does a woman go about it? First of all, one moment. Right, sorry. So she becomes, she stays fasting. She can take water if she wants to, but the minimum amount of fasting that needs to be done are 8 hours. Okay. However, 10 hours is also can be used. So you can have a 10-hour fasting or 8 hours. Why 8 hours? Because these women are pregnant. So the recommended is 8 hours. So by about say 12 midnight, if she starts fasting, then she can give her first blood at 8 o'clock in the morning. Okay. So with a minimum of 8 hours fasting, she goes in for a first to give blood, that is a fasting blood sugar. Next, she is given 70 grams of glucose diluted in 300 ml of water, right? You can add a bit of lime if she wants to, because that causes them to be less nauseous and they will not vomit it out. And then once that is done, and there are special sachets of glucose that can be given in a more edible format, so those can be used, but simply normally the labs will give 75 grams of glucose to be dissolved in 300 ml of water. Then once it is taken, another blood is taken 1 hour, that is the first hour, and then again another blood is taken the second hour, right? So that is a standard 75 grams oral glucose tolerance test, minimum of 8 hours fasting. That includes a fasting blood sugar, then glucose 375 grams in 300 ml of water, and then 1 hour and 2 hours. So basically a 3-point blood test. Is that clear? There are different kinds of OGTTs that are being used. Now there are OGTT tests which takes the fasting blood sugar, and sometimes 75 grams or 100 grams can be given. So these are different variations, but now the world seems to have settled on a 75 gram glucose test. And then sometimes the first hour is omitted and only the second hour is done. Okay, so it is 2, fasting, glucose, and then 2 hours after glucose. So that is one way of doing an oral glucose tolerance test. Okay, sometimes there are different kinds. Glucose is given, then half an hour, 1 hour, 1.5 hours, 2 hours, those are also taken. These are very flow-wrong tests which are not used commonly now, because they do not give us any additional information. Is that clear? Right. So I normally, and most of the colleges and the associations will recommend a 75 gram 3-point oral glucose tolerance test. Okay. And that I think probably is valid for you to go with. Now the problem comes in interpretation. And that is where the problem is. Because if you set your values very high for the diagnosis of diabetes or gestational diabetes, right? We might miss a group of patients who are actually diabetes, but our test does not indicate that they are. You all understand? If you put the values down very low, okay, to diagnose diabetes, right? That means, say, one value, shall we say, the second hour is 153. We take the second hour. So we diagnose all the patients of having diabetes if the second hour value is more than 153. Okay, so that is an example. However, if there's a few patients who are having diabetes, but the second value is less than 153, say 145, then we will miss those and we will not diagnose them to have diabetes. Okay. If you set the second level at 140, then we will have a larger group of women who we diagnose as having diabetes. But what you remember is sometimes they may not be diabetic. So you might have more women without diabetes in the group who we diagnose as diabetes, right? Depending on the values which we set. So the biggest controversy in gestational diabetes at the moment, from what I understand, are the cutoff values. So different studies will give different cutoff values. Different population will have different cutoff values. So WHO will have different guidelines. India, they had a large study called DIPSI, diabetes in pregnancy, right, in the Indian population. And their cutoff values came as slightly different as well. Okay. So the WHO will recommend different cutoff values depending on the country and all. So universally, these cutoff values is a big problem. So if you look at each of these organizations, WHO, NICE, college, our college, and FIGO, you will find different cutoff values for all these organizations. So what you can do is keep those cutoff values in mind. Just look at them and just write FIGO this, WHO this, right? NICE this, college this. Okay. However, keep that in mind. But in your practice, because it will be your unit practice or hospital practice, stick to one. Otherwise, there is no end to the complexities that you will encounter when you have different types of guidelines. Okay. For me personally, children, I use the HAPO study for the, and that HAPO study will also have the recommendations of several organizations, and that is being used. This is a controversial thing, as I told you, but I, for myself, I use this HAPO study guidelines for the moment, right? What are these? Fasting blood sugar cutoff value is 92 after 8 hours of minimum fasting. After glucose, the first hour is 180 milligrams per deciliter, and the second hour value is 153 milligrams per deciliter. Okay, so these are the values I personally use. However, this is a very controversial topic. So these are based on hypoglycemia and pregnancy outcome study in 2008, and they may differ or change with time. Sometimes the second hour value may be recommended as 120 as well, right, in some countries, right? So therefore, we need to be very careful as to what to use. Remember, second hour is 140, right, not 120. So therefore, there's a huge difference between 140 and 153 is the second hour value, right? So therefore, we need to be very careful as to what we choose to do. So please base your recommendations on when you talk. Okay, so just say that it is the unit policy. Okay, is that clear? So for me, I use 92, 180, 153. And for the moment, I have no reason to change it, but may change it in the future depending on what other evidence will come to light, because we need to change our practice depending on the evidence and the new criteria that comes along. Okay. Now, what are these based on? These cutoff values are based on the number of problems that a woman may have or may not have due to diabetes. So therefore, these are based on the chances of the baby getting large, which is called macrosomia. The chances that the baby may have a lot of urine around the baby, that is polyhydramnios. The chances of the cord, different kinds of chemicals in the cord, which shows that the baby is having some form of diabetes or glucose intolerance or non-controlled in the mother, right? Then the chance of the baby developing complications due to diabetes. For example, hypermagnesemia, hyperbilirubinemia, hypercalcemia. So different kinds of neonatal problems are also included in that. So how does it happen? Okay, if the baby had a lot of problems, okay, they go back and check, okay, look, the cutoff value was 153. 140, but the baby still had this problem. So therefore, probably we should have a lower cutoff value to diagnose the problems. Do you understand? So you compare the neonatal outcomes and the maternal outcomes with the cutoff values and try and compare them and then get a value where there are no complications. And okay, less than that, probably then it is not gestational diabetes. If the baby starts having complications, the mother starts having complications, maybe we should have put the cutoff value here so we catch all of those and then treat. Do you understand? So that is how in these studies, the problems and the cutoff values are correlated to try and find a middle ground, right? Do you all understand? So therefore, because if you include a lot of women who are not having diabetes into a diabetic group by our cutoff values, we start to overtreat them. We will give unnecessary diets, medication, insulin, all these are risky things to do. Do you all understand? So we need to find the good grounds. For the moment, that is why the controversy is there. Is that clear, children? Right? Okay. So let's go with one cutoff value for the moment, right? Which is based on, as I told you, hyperglycemia and pregnancy out of HAPO study, which is 92, 180, and 153, right? If you look at these organizations, they will recommend different kinds of cutoff values as well. Okay. Now, how do we diagnose gestational diabetes? If one of the values of anything is higher than the norm, then we diagnose gestational diabetes. Is that clear? So now we have a woman with a diagnosis of gestational diabetes, right? Now what do we do? Therefore, every woman who is diagnosed with gestational diabetes requires treatment. That is the bottom line. Okay? So treatment, right, is in different forms. So whether it is diabetes, now let's go back to the initial stage. Okay, even if we diagnose diabetes in the first trimester of the booking visit, or even if we diagnose diabetes between 24 and 26 years, now we have a woman with a diagnosis of diabetes. Now comes something which is very important, children, right? If the values are extremely high, right, then our treatment might change. Initially, if the values are over 200, for example, in the second hour, right? Or the fasting blood sugars are maybe over 126, 130 or very high, okay? Then comes into our mind, is this pre-existing diabetes, which is hugely uncontrolled? And therefore, you might need to start on a different treatment regime, which we'll discuss in a minute, okay? So let's talk about a woman who is having, we have diagnosed gestational diabetes. The first thing which we need to do, if there are no complications clinically or biochemically at that point, what are these complications that can be there at that point of time? Number one, we may diagnose it at a time where the baby is extremely large. We are sure of the dates, but the baby is large. Now we already have macrosomia. We may diagnose gestational diabetes at the time when there's a lot of amniotic fluid, right? So that there is already a complication. We may diagnose a form of diabetes when the woman has gone into ketoacidosis. She comes with ketoacidosis, and then suddenly you diagnose she is having diabetes. Then a woman might come, I am feeling thirsty all the time, and you do a diabetic test and she is diabetic. So most probably it's pre-existing diabetes. Then a woman may come that she has a lot of thirst, or she passes a lot of urine. Then you try it. So in these women with some sort of non-control or complications, our treatment pathway may be slightly different to what I'm just going to tell you in a conventional, not complicated gestational diabetes. Is that clear? So let's go along one pathway, which is routine patient with gestational diabetes diagnosed, right, without complications. So the number one thing we do first is to communicate with her. Tell her, okay, this is probably gestational diabetes. Or if we have a suspicion, we might tell her, okay, this may be pre-existing. So therefore, we need to have different kinds of regimes and treatment. But after pregnancy also, we need to follow you up. Okay. So number one, we communicate with her and tell her. Now with gestational diabetes, in well-controlled gestational diabetes, the outcomes are almost similar if we manage them well to patients who are not having gestational diabetes, right? But if we manage them properly. So what are these outcomes we talk about? What are these? If you know, there may be maternal problems and fetal problems. Okay. What are the maternal problems? She can have a very distended large baby, or in fetal we can have macrosomia, we can have polyhydramnios, right? There is a small slight possibility that the baby might have problems and might cause death, but this is extremely rare. Then once the baby is born, the baby can have problems like neonatal hypoglycemia. Why hypoglycemia? Suddenly the baby's glucose falls because due to gestational diabetes, there's a lot of glucose coming into the baby. And the baby's pancreas will become large and produce a lot of insulin. When the baby comes out, when the cord is clamped, no more glucose is coming from the mother. If it does not take good, suck enough milk, right? But the baby's pancreas is working well, a lot of insulin, and there is immediate hypoglycemia. So the baby can go into hypoglycemia. Everything else is hyper, right? So hypoglycemia. Then all the chemical problems can come up because of the problems with metabolism. So the baby can experience hypocalcemia, hypomagnesemia, all these elements can go down because that exchange does not take place and the metabolism does not take place properly. What is the other hyper thing? Is hyperbilirubinemia. Because what happens is, the baby can have polycythemia because although the baby is large inside, this is especially in babies with pre-existing, mothers with pre-existing diabetes. Although the baby is large, what happens is almost all the organs in the baby's body is existing in a state of hypoxia. Because although the organs grow, the blood vessels that provide these organs do not grow relatively as fast. And therefore, the large organs, but they are not very healthy. And therefore, they have relative hypoxia. And these are hypoxic large organs. Okay, what are the only two organs that the insulin does not cross? The brain and the testis. No? There's a blood-brain barrier and there's a blood-testicular barrier, right? These are not very sensitive, but the rest of the organs can become relatively large. So therefore, when the baby comes out, most of the organs are hypoxic, and therefore that is why there is all hypomagnesemia, hypokalemia, hypocalcemia, all that. However, because the baby is hypoxic, relatively, more erythropoietin is secreted and there is more blood cells and they have polycythemia. Once the baby comes out, the destruction goes on very much and then therefore bilirubin goes fast. So the babies they become jaundiced and they have hyperbilirubinemia. Okay. So these are the things that you need to watch out. But you have to remember, in women who are having gestational diabetes, all these complications are rarer to actually women who have pre-existing diabetes. But remember, you have to remember what? If the woman did not have a diagnosis of gestational diabetes and she did not know about it, and she becomes pregnant with it, there is also this group of women who we are going to label as having gestational diabetes, but maybe having pre-existing diabetes. So these women may, and the babies also may have these problems. Remember that. Is that clear? Right. Good. So the first thing that we need to treat them is with what? What you call MNT, or medical nutritional therapy. Okay. Normally in every unit, children, we will have a diet chart. Or if you want to do it perfectly, you send the patient to a nutritionist or a doctor with special interest in nutrition, or there are our postgraduates are there and consultants are there in nutrition, or you can send them to your nutritionist in your hospital. Every government hospital, most of the large hospitals will have a unit for nutrition, right? So a dietitian or nutrition. Actually, it's a nutritionist and not a dietitian. So therefore, They will discuss with the patient what her normal meals are, how she is eating and all that, and then advise or give her an individualized diet plan. But sometimes that does not happen. We have a universal sort of diet plan and a nutritional plan which we give her. The main area for this is you cut down on the carbohydrates, keep the rest of the things at a normal level, and give the rest of the minerals and the vitamins, everything there. Clear? So you start on. So other principle behind this is, children, you have smaller frequent meals with snacks in between, okay, with a lot of fluid. Okay, so that is the normal way. So breakfast, you have smaller breakfast with smaller amounts, especially carbohydrates. Then snack around 10 o'clock or so. Then patient has lunch. Then there's another snack, then there's dinner, and there's a snack before. So number of meals increase, number of snacks in between, because it's difficult, will also increase, but the amounts will become smaller. So therefore, that is how normally a diet or medical nutrition therapy is assessed. But it's better for her to be in touch with a professional so that the diet is followed up properly. Is that clear? Depending on the initial values, once the medical nutrition therapy is given, she starts on that, right? And then we need to find out, is her diabetes, gestational diabetes, controlled with our MNT? So that is the next step. And then comes the next terminology, which you all have to understand, is how do we measure control? Right, somebody said we can't hear. Right, I can see Chamod. Can you hear me, Puta? Thumbs up. Yeah, Kasun. I can't see Kasun, but I can see a beautiful picture of him. Okay. Oshadi, can you hear me? Yeah. Okay. Sakuntala, I think probably something wrong with your computer. So check it out. Okay, Puta? Right. Shall I continue? Yeah. Okay. Then now I lost the thread. Medical nutrition therapy. Right. So then comes the next definition that you have to understand. How do we measure control? And that is what we call monitoring. How do we monitor? So remember three terminology which you need to know. First is screening, okay, and what to use. Second is diagnosis, which is the oral glucose tolerance test. Third is monitoring blood sugar control, and that is done by what we call the blood sugar series. Okay. Now, blood sugar series is done by doing different blood sugars at different times of the day, right? So there are different kinds of BSSs. We call them blood sugar series or BSSs, right? And there is also a huge controversy about the blood sugar series that we are doing. Okay. There are 7 point, 8 point, 4 point, 3 point. There are different kinds of blood sugar series which can be done. If you want to trouble the woman a huge amount, what can we do? We can do a blood sugar at midnight. We can do a fasting blood sugar. Then we can do a 1 hour after breakfast, 2 hours after breakfast, then 1 hour pre-lunch, 1 hour post-lunch, 2 hour post-lunch, 1 hour pre-dinner, then 1 hour post-dinner, then 2 hours post-dinner. Can you do it? So you can do all sorts of things, right? Then you can do a simplified blood sugar series like what? A fasting blood sugar, then 1 hour post breakfast, 1 hour post lunch, 1 hour post dinner, only the postprandials. Or you can do fasting blood sugar, 2 hours post breakfast, 2 hours post lunch, 2 hours post dinner. Okay. So lots of variations are there in the blood sugar series, right? So now now comes the cutoff marks. And what is our aim in doing a blood sugar series? Basically, it's best to think about one cutoff mark than to go for several cutoff marks, right? in our practice, in our unit, we use simply one. Fasting blood sugar, we want it to be below 95. That is our cutoff mark, because remember, fasting blood sugar reflects the overnight control. So whatever problem she has been having overnight, it will be reflected in the fasting blood sugar. Okay. So when we are looking at the fasting blood sugar, we are thinking about the 12 hours which she had prior to it. And if it is high, we think that yes, in the night, there has been some problems, ups and downs, and then finally fasting remains high. Okay. Then you can do pre-meal or post-meal, 1 hour or 2 hours. But what has been found, the evidence is that sometimes it seems that the 1 hour postprandial seems to be correlating more with the chance of baby getting bigger or macrosomia, right? However, it's a controversial topic. You can use a 1 hour value or a 2 hour value if you want a post-meal. Normally, the 1 hour values are, the cutoff values are at 140 and the 2 hour cutoff values are at 120 milligrams per deciliter. However, units may use different cutoff values. I personally use fasting blood sugar with a cutoff value of 95 and each postprandial, 1 hour postprandials with a cutoff value of 140, right? However, some units may use 120 as the second hour cutoff value as well. Is that clear? So we give medical nutrition therapy and we do a blood sugar series. And we hope that with that, all the blood sugars which you do are less than our cutoff value. And we think that the patient is sort of biochemically controlled. Is that clear? So you choose your own blood sugar series or the cutoff values and they may differ. The blood sugar series may differ from 100, but what you need to have or understand is that you need to be thinking about the unit policy, right? And the different organizations may recommend different cutoff values and different blood sugar series. Okay, so that you also have. So, however, what is essential is once the diagnosis is made and once therapy is started, like medical nutrition therapy, we have to have some form of monitoring of the blood sugars to make sure that we are achieving our targets, because in our brain there are targets as to what control should be, right? Is that clear? So the targets, if you take 95, our target is to keep the fasting below 95 and the rest of the postprandial is 1 hour below 140 or 2 hours below 120. So that should be the target. Okay, right. The next thing is there are different ways of principles of monitoring. There's another principle called home blood glucose monitoring, where the patient monitors the blood sugars at home, or self blood glucose monitoring, right? So where the patient monitors the blood sugar. So there are different ways. Now, most countries will sometimes use home blood glucose monitoring. Now remember, there are two ways of measuring blood sugars. One is venous, the other is by finger prick or capillary. Now these cutoff values are also different. So you have to use a different set of cutoff value for capillaries. If you are doing it as home blood glucose monitoring with capillary blood sugar, the patient measures it herself. Or if you are really doing venous, then she has to really go into a lab and get it done. Okay, because the venous blood needs to be drawn. So the patients are very happy sometimes to use just capillary blood sugars, but they may not be extremely accurate. However, what is good about capillary blood sugars or whole blood sugar monitoring is that the patient finds it extremely easy, right? At the same time, you can do it more frequently than ask the patient to visit a lab every 2 to 3 days, or you can do it even on a daily basis, right? So therefore, and randomly at different times, and therefore sometimes maybe than just 1 weekly or 2 weekly venous blood sugar series, sometimes home capillary blood sugar monitoring may be even superior. But of course, these are just ideas. In Sri Lanka, we normally rely on, because sometimes the patient cannot do them herself. So therefore, we normally rely on conventional blood sugar series every 2 weeks or sometimes every week, but usually it's every 2 weeks, we rely on a conventional venous blood sugar series. However, it can differ from unit to unit, consultant to consultant, or hospital to hospital as to what exactly you use for monitoring of diabetes in pregnancy. Is that clear? So remember, if you are using one thing, you need to know which cutoff points are there, what values to use, and how frequently you have to use. If it's a different way of continuing, whether it's capillary or venous, then the things will, cutoff values will change. For that also, you need to know what cutoff values you need to take. Is that clear, children? Right? So that is monitoring. The frequency of monitoring also can change. So that is also unit policy. You can do it every 2 weeks or 1 week. If it is home glucose monitoring, every day or every second day. So that, of course, there are no, but principally, the more frequently you monitor, the better the control. So that is the principle. So you have to come to a compromise as to how much you can ask the patient, how many times you can ask the patient, or how frequently you can ask the patients, depending on your country, your circumstances, her social circumstances, the amount of her financial status, and everything, as to what you can ask the patient do. Because there are patients who may not be able to afford a home blood glucose monitor. The strips may be expensive, and there may be patients who cannot afford to do blood sugar series every week or every third day. So then probably we have to settle for maybe 2 weekly. However, 1 weekly blood sugar, venous blood sugar is superior to a 2 weekly venous blood sugar series. That is obvious, right? Because then we get more data. However, it may not be very practical. So depending on your country, where you are practicing, the practices of monitoring blood sugar will change, right? And in our unit, we normally go for 2 weekly blood sugar series, which is a bit drawn out and may not be the ideal. But then the patients find it more easy to do a venous every 2 weeks than to try and give blood 4 times a day every week. Is that clear? Right. So remember, now from medical nutritional therapy, now we go for monitoring. Next, with the monitoring, right? If she is well controlled on medical nutrition therapy and our blood sugar series, which we have taken, shows us that she's clinically all right, then we can continue the pregnancy on that. So that is how we go along. Now will come an instance, right, where suddenly we find with the maximum medical nutritional therapy, and she is very compliant as well, there will come a time, or might come a time, where your blood sugar series, according to your cutoff value, shows that it is not controlled. So from my point of view, anything fasting over 95 or 1 hour postprandial over 140, and say if she has, say, 110 fasting, 153 post breakfast 1 hour, 160 post lunch, and 170 post dinner, then of course we are looking at a blood sugar series. Despite the medical nutrition therapy, we are looking at a diabetes which is not controlled biochemically. See, I keep on telling you it's biochemically because it's a blood sugar series. There are other factors that come in. There is clinical control, which we look at. I will just tell you what are these clinical control. Clinically, we judge whether there is a problem. What are the 3 most important reasons? Macrosomia and polyhydramnios. Lot of fluid around the baby because the baby is urinating more due to hyperglycemia in the baby, and macrosomia because the baby is becoming bigger due to probably insulin-like growth factor 6, which is produced more in diabetic babies, right? All the organs become larger, but they are not healthier. Just because it's large does not mean that the baby's organs are healthier, right? And when they climb, the baby's estimated fetal weight climbs over the 90th centile, we call it macrosomia. Rarely we might get growth restriction in babies, but normally not in gestational diabetes, pure gestational. But if it is pre-existing and we diagnose them during pregnancy, yes, these babies, because of placental problems, may become even smaller. So we can have 3 problems: small for gestational age, macrosomia, and polyhydramnios. These are the 3 commonest things, right? which shows clinical non-control, but at the moment we are talking about biochemical control at the moment. Is that clear? Now, we have reached a point where our blood sugar series shows that there is a problem. Okay. Now we need to introduce medication. So what is the commonest form of medication which we have evidence is metformin. There was a trial which is called metformin in pregnancy, right? So therefore, this trial which is called the MIG trial, MIG, right, was used as a basis to use oral hypoglycemic agents. At the moment, usually some will recommend few things, but the metformin is recommended across the board by all the organizations. So metformin has been found to be safe. It's widely used and can be introduced as the first line drug in when we find that the blood sugar series shows that the control is not there. Is that clear? So metformin, how do we introduce? In that trial, metformin was used up to a dose of 2,500 milligrams. Okay. So therefore, that is the evidence-based safe limit, that is trial-based. However, now evidence is coming up. Yes, we can go even higher and higher, but maybe it is safer for us to stick to maybe 2,500 or 3,000 milligrams per day of metformin to try and control. What is the minimum we give? 500 milligrams 3 times daily. 500 milligram TID. And how do we give metformin? We give it on top of the diet, and the metformin is normally advised to be taken just before the meal, the 3 main meals. Just before breakfast, you take the metformin and you sit down to eat. Lunch also, you take the metformin and she sits down to eat. Dinner also is the same. Do you all understand? So 500 milligrams 3 times a day is the starting dose. And then what you do is, while she is on diet and while she is on metformin, then at a sort of acceptable interval, maybe 1 week in some minutes, maybe 2 weeks, right? After taking metformin, then she does another blood sugar series. And then you look at it again. Okay. And then we see whether it is within the ranges of what we want. If not, depending on the amount of which value was increased, you start to increase your metformin, because you can go up to about 2,500, 3,000 per day, right? Say if your post-breakfast was all right with 500, then you leave it at 500. Say if your post-lunch is high, and say, since we started on 500, then you can make it 1,000. And then if your post-dinner was all right and your fasting was all right, you can leave the 500 as usual with your dinner. So you give them 500, 1,000 and 500. And again, you have to repeat the blood sugar series at a reasonable time to find out whether your new 1,000 is working. Okay. And if not, then again we have 2,000. Now we are going to, then again you can adjust your metformin. You go on adjusting your metformin till you are given about 2,500. Okay. So once that is done, still if you are not achieving control, then you have to switch on to diet, that is medical nutritional therapy, plus your maximum dose of metformin, and then you add on insulin. Okay. So that is our pathway which you do. So getting back to oral hypoglycemic agents, one of the agents that have been recommended is glibenclamide, which can be also used. But in Sri Lanka, we the unit which I work, usually we go from metformin, and then from metformin, we normally do not, or it is not recommended to add 2 types of oral hypoglycemics. If one you control, then you can switch on to insulin. However, there are various studies that are coming up by combining different kinds and types of oral hypoglycemics, but those are all in the trial stages and there are no recommendations yet. So it's better to think about oral hypoglycemics for the moment as monotherapy, medical nutrition, and then you go with maximum to with one oral hypoglycemic drug and still we will not control, then you switch on to insulin, right? Then what are the recommended insulin regimes? A lot of regimes are there and lot of types of insulin are there, which you need to understand, right? There are very rapid acting insulins, there are soluble insulins, there are short acting, medium acting, then long acting, right? There are different kinds of, there are synthetic insulins, there are insulin analogs, different kinds have come up. But now, still the most recommended regime, right, for which achieves the most amount of control, which gives the least amount of fetal and maternal complications, still remains pre-meal bolus injections of insulin. Okay, so that is the standard regime that is going on even up to now, and it probably until we get new evidence will remain our standard starting schedule as MBBS students. As postgraduates, I see a few here. You have to understand that you have to know all the pros and cons of every type of insulin, right? And insulin analogs and the data available, right? Which is as part all the data meal, all the new ones, okay? Right? That is for you all to study. For MBBS children, soluble insulin, pre-meal, and a long-acting insulin in the night is what you have to keep keep in your brains. Is that clear? So you have what happens. So if you give insulin before a meal and she eats, then she gets another pre-meal insulin and she eats. That's soluble insulin or fast-acting. Then she takes another insulin and she takes dinner. And then to control overnight, at about 10 o'clock in the night, she needs to get a long-acting insulin, isoprene insulin. Okay, so that is how. So 4 doses, 3 pre-meals, right, fast acting and a long acting insulin in the night. So that is the standard regimen that you need to remember as medical students. You are not going to be asked about short acting, median acting, different regime. That of course we will ask all the postgraduates in detail when we see you, right? So do you all understand? So remember, insulin children is what? 3 short-acting pre-meals with a long-acting in the night. Okay? Is that clear? Next question is, how do we practically add insulin? Right? So there is a rule of the thumb way of adding, which I'm going to tell you. Right? What we do is, for all the postprandials, we add 1 unit of insulin for every 10 milligrams per deciliter of glucose, which is over 100, right? So let's look at it this way. First of all, when you do a blood sugar series, right, we check whether these are controlled, fasting and 1 hour postprandial. So now if you have reached a maximum of metformin, right, and maximum medical nutrient metformin, now we have come up to the stage, okay, we need to add insulin. Now if you are looking at a blood sugar series of, shall we say, fasting blood sugar 92, is that normal? Yes. 1 hour post breakfast is 150, is that normal? No. Post lunch is 160, is that normal? No. Post dinner is 180. Is that normal? No. Please write. Okay. Now we know, yes, we need to add insulin. Now, how do we add? Now, since we have decided to add insulin, so the decision is now taken. Now, how many units to add? Say if the post breakfast is 150, okay, what is our rule of the thumb? Right? Anything over 100, we add insulin. So how many units over 100 is 150 milligrams per deciliter? It's 50 milligrams per deciliter over there. Okay. And then we add 1 unit for each 10 milligrams per deciliter. So how many units do we need to add? 5. Clear? So pre-breakfast, she gets 5 units and eats. Okay. Post lunch is how much? I said 160, right? So how many units do we need to add? 6. Good. Then she injects herself 6 units and eats. Post dinner is 180 children. You have to add how many? 8. The decision for adding insulin is 140. Okay. However, we add insulin, everything over 100, once the decision is taken, we add 1 unit each for every 10 milligrams per deciliter. Is that clear? Now, how do we add the long-acting dose? That is empirical. There are no rules of the thumb, right? So looking at the fasting blood sugar, we are aiming that overnight. Then say if it is 97, then probably we can add about 4 to 6 units of long-acting insulin for the night. And then next day we can look at it, right? Then what we do is, we do a blood sugar once we have added insulin, right? Now our patient is on diet, on metformin and insulin. And then maybe you can, in 3-4 days, it's better to do another blood sugar series and see, right? So let's say now the fasting, now what is, so because shall we say now she is on 5 units, 6 units, 8 units and 4 units in the night. Okay. Now we do another blood sugar series and finally find that the fasting blood sugar is 100. Is it bigger, more or less? It's more. The post breakfast is 130. Is that all right? All right. Post lunch is 150 despite our insulin. And post dinner is 120. Is that normal? Normal. Right? So then again we readjust the insulin. How do we readjust? Post breakfast, we keep it as it is. We had 5, right? Initially. And now it is, what is the value I said post breakfast? Something less than 140, right? So which is normal. So we keep it as 5. Then we look at lunch. We added 6 units earlier, right? Or 5 units. Then lunch, okay. So lunch, what is the new value I said?
150, sir.
150. So on top of what is still it's not controlled. So we have to add 5 more units to what we had earlier. So what did we have earlier? How many units? 6, yeah? Right. So 6 and 5 we add and we make it 11 pre-lunch. Dinner, how much did you have? It's normal. So, but we added 8. So therefore we keep it at 8. However, long acting we added 4 initially, but now it's 100, which means probably we need to add maybe another 4 or 6. So we will make it about 8 and see whether it can. Do you understand? This long acting, there are no hard and fast rules. Is that clear, children? Do you understand the principle behind it? So this is how we keep on adding, keep on changing until we get control. Once we get control, then again we can go back to our routine, normal routine of frequency of doing blood sugar series when we achieve control with insulin. Is that clear? Right. So we go on till until delivery. Now what we have to remember is, there are instances where we might initiate insulin directly without going through all this without going through medical nutritional therapy, without waiting for it to control, because all the alarm bells might start to ring if certain things are present, and our medical nutritional therapy and oral hypoglycemics may not be sufficient for us to control the diabetes quickly as we want it. What are these instances? Initially, if the fasting blood sugars are very high, over 126, we think it to be high, okay? Or the second hour values are over 200. Then you start off on insulin directly, and then you control everything. Doing BSSS, you control it insulin only. Of course, medical nutrition therapy plus insulin, right? Along the way, if we suddenly find that the clinical controller is not there, macrosomia is starting to develop, because we have to do serial growth scans and we plot them on a graph from about starting from what 28 weeks or 24 if we diagnose the gestational diabetes at 24, we start plotting them. we diagnose at 28, we start plotting. There are charts, serial growth charts, which has the 10th centile and the 90th centile. Less than the 10th centile is small for gestation, over 90th centile is macrosomia. So we hope that it's in between. So suddenly in the chart, if we find macrosomia, then our maybe metformin and medical MNT is not enough for control. So we switch on to insulin, right? Suddenly, if she develops polyhydramnios, we might switch on to insulin. Suddenly, if we find that the one of the blood sugar values are very high, right, and our medical nutrition and our oral hyperglycemia are not working very well, we might have to switch on to insulin. Do you all understand? So depending on certain things like polyhydramnios, the presence of macrosomia, very high values and very uncontrolled blood sugar series, if she's only on medical nutrition therapy or metformin, we switch on to insulin in those instances to gain better control. Is that clear? And especially in all diabetes, if it is suddenly diagnosed in the 3rd trimester and we have no time to start MNT and metformin and wait for it to go down because she's going to be near delivery, in those to achieve control, also we have to start with insulin. Is that clear? So those are the instances where we will start off with insulin directly than wait for metformin to do its job, because that will take some time. Is that clear? Right. So now that is how we control diabetes during the pregnancy. So now we approach what? Once you have done that, we approach what we call around 36 weeks. There are several things that we have to find out, right? So along the way in the monitoring, we monitor the mother biochemically, and of course we monitor the fetus. And how do we monitor the fetus? By ultrasound scans, which is normally at 3 to 4 weekly intervals. And what do we look for? Macrosomia, small for gestational age, sudden changes in the pattern of growth. Right, which is rare in gestational diabetes. So macrosomia, small for gestation, and polyhydramnios, where the single deepest pool may be over 4 centimeters. Okay, so there are polyhydramnios. There are discomfort. Then you are looking at bad control, and therefore you might need to be on the lookout. So fetal monitoring must be initiated around 24, 26, or whenever you start find that she's having diabetes, you have to initiate growth monitoring by ultrasound scan. Is that clear? Right. So fetal movements then in a lot of fluid. So in that case, you might need to do ultrasound scan to find out whether the baby is moving as well. So then you monitor the mother and you monitor the baby, and then you go along. And then around 36 weeks, there are several decisions you need to take. Number one, timing of delivery. Second is the mode of delivery. Okay. So timing of delivery is simple. If the woman is on medical nutrition therapy only and well controlled biochemically, and you can go on until about 40 weeks. Okay. Second thing is, if the woman is on therapy of any sort without complications and well controlled, right? Yes. But if she is on metformin or insulin, it's better to deliver around 38 and 39 and not wait till about 40. Is that clear? So fully controlled on medical nutrition therapy only, you can go along the pregnancy until about 40, 41 weeks as a very normal pregnancy. Medical nutrition therapy plus metformin or insulin, fully controlled, you can go on till about 38, 39. Okay. Medical nutrition therapy with medication and insulin, if complications start to come out, right, which may be polyhydramnios, macrosomia, fetal distress, maternal problems, maternal diabetic ketoacidosis, symptomatic, then you might need to think whether you need to deliver earlier than the dates which I told you. Is that clear? So that is the timing of delivery. Mode of delivery, diabetes is not a contraindication for gestation for a vaginal delivery. So you can go for a vaginal delivery. However, if the baby is macrosomic or having problems, right, then of course you might need to think of a cesarean section. However, cesarean section is not an indication to deliver by cesarean is not an indication for a woman who is having diabetes. However, you might need to think if the baby is macrosomic or having complications, right, very large babies, you might want to, or sometimes you might have to consider the cesarean section. Okay, so that is the timing of delivery. Now, during delivery, especially for macrosomic babies, right, or then in the first stages, you will need to monitor everything well. Second stage also, third stage also, there's a possibility that the glycemic control may go up and down during delivery. And therefore, for these patients, during the delivery, you need to have very good glycemic control. So we have to keep the delivery during labor, we have to keep the blood glucose levels at certain levels. Accepted norm is to keep something between 100 and 120. So there may be. So that is your delivery, which you need to glucose levels, which you need to think about, right? Okay, so before we come to delivery, let's recap as to what you're. Any questions so far as to what we need to do? Anything? Did you all understand how it's managed and what the general principles are? Okay. So then finally, now we are coming to delivery. In the delivery, there are different kinds of women. Now, women who have come up to this delivery time with medical nutrition therapy only. These women, you really don't need to make any difference with a normal woman. You can just go with the delivery in the same way as you go with any normal woman, right? If there is medical nutrition therapy with no complications, mother or not, then you can eat the normal sort of delivery. You don't need to worry too much. Then there will be women with metformin and medical nutrition therapy. So for the labor day, you take off the metformin, you don't give metformin, and then you monitor them in the same way as usually. However, in these women, you may need to monitor the blood sugar at intervals. The standard regime is you do capillary blood sugars every 1 to 2 hours throughout the labor. Okay, and then if they are hyperglycemic or hypoglycemic, you may need to give intravenous glucose if they are hypoglycemic, and if they are hyperglycemic, you might need to add on insulin during the labor. Okay. Then for women who are on medical nutrition therapy and insulin, we need to monitor the labor very, very, very carefully. And that we do by checking the blood sugars every hour, right? And usually capillary blood sugars every hour until delivery and post-delivery as well. Now, how do you do it? Ideal way of managing it is to put in several lines, one line with a three-way tab. And how do you manage that? There are two large principles of management. The perfect way of managing a patient who is diabetic on insulin, who may have swings up and down, is to put her on a sliding scale, right? So how many drips are going in? Number one, there's one drip going in with the oxytocin if she requires that. So that must go in regularly. And that probably should be given in a separate pump or a separate drip that goes into her. The second thing is you need to have an insulin, preferably with the insulin syringe pump, right? Where we can adjust the amount of insulin going into the woman, right? So we can adjust whether it is 1 unit, 2 units. Normally we put 50 ml of normal saline and 50 units of insulin. So it is 1 ml contains 1 unit of insulin, and we put it in a syringe pump, and then we put the drip in her so that it goes into her. Okay. The third drip that she must have is a dextrose drip, which contains dextrose, which may be shut off. And then the fourth drip, actually, we have a dextrose drip and a saline drip, right? So you have hydrator, you can give oxytocin, you can give glucose, and you control the insulin as well. So that is how we normally, in ideal circumstances, we manage. And how do you manage that? You do the capillary blood sugar every hour, and then there's a scale, a sliding scale. It says less than this, shut off the insulin and start dextrose. If it is between this and it seems high, increase the insulin and take off the dextrose. The hydration is going on and the oxytocin is going in, okay? If it is very high, increase the insulin. If there is hypoglycemia, stop the insulin or decrease the insulin, and you might or might not want to start the dextrose strip. Do you understand? So the logic behind is, on a sliding scale, you increase or decrease or shut off glucose, you increase or decrease insulin or keep it at the same level if the level is desired. You give the hydration separately and the oxytocin goes in separately by syringe pump. Is that clear? So that is the way you have to ideally manage labor. The other one is a bit different. You make one drip of putting dextrose, potassium. Of course, we have to put potassium because the insulin uses up the potassium. You make a dextrose, potassium, and you put the insulin in there also, which is not really physiological. Because the moment you open it, dextrose goes in, potassium goes in, insulin goes in at the same time. And sometimes it might be difficult to manage. So that is not a very acceptable way, but it is sometimes still practiced. But the better way is to give insulin separately, dextrose and the potassium separately, hydration separately, and the insulin separately, oxytocin and insulin separately by their respective pumps. Is that clear? So your aim is to keep the woman blood glucose between 100 and 120 constantly until she delivers. Okay, so that is the aim of the whole exercise. Once she delivers, remember, during delivery, what are the risks? Shoulder dystocia is a possibility in babies with women who are having diabetes. Shoulder dystocia is a possibility, so it's better to have good neonatal support at that point of delivery. Okay. Once the delivery has taken place, what are the risks? She can have postpartum hemorrhage. Why? Because the baby would have been large, may have had polyhydramnios, and therefore the uterine contractions may not be ideal. And therefore, she can have postpartum hemorrhage. She can have trauma, tears, instrumental deliveries due to shoulder dystocia, a lot of trauma. All those are possible during delivery. So you need to be on the lookout for postpartum hemorrhage and tears, right, due to trauma. And of course, the baby can be traumatized if the baby has shoulder dystocia. Soon after delivery, her glucose levels can fall because the placenta has gone off. It's no longer giving any problems to the mother. And then the woman has produced a lot of insulin during the time, and therefore she can have hypoglycemia, and even that she can have hyperglycemia. Right? So you need to monitor the woman very carefully in the immediate postpartum period and then in the puerperium as well. The baby can have all the problems which I told you. The baby can have hypoglycemia episodes, baby can have hyperbilirubinemia, hypomagnesemia, hypokalemia, hypocalcemia, all the metabolic problems the baby can have after delivery. So especially the pediatricians will monitor the blood glucose of the baby soon after delivery carefully for some time, especially if the woman was on insulin or oral hyperglycemia. Is that clear? Then after that, cesarean section is the same. However, pre-operative, you have to make sure that the blood is fully controlled. During the operation, it's a short period, and then post-operatively, it's the same monitoring that needs to go on for the baby and the mother. In the puerperium, since we are talking about gestational diabetes, we stop all medication, right? And then we ask her to get back on a normal diet, and then after 6 weeks, we test her again for doing a diagnostic test for diabetes. If there is diabetes after 6 weeks, then we make a diagnosis. Yes, this is the woman who had pre-existing diabetes before she became pregnant, right? Only we know. So therefore, after that, she has to be referred to a physician or an endocrinologist for further management, right? If it's normal, then you advise her. What are the advices? Next pregnancy, you can have diabetes. It's better to check yourself every year with a fasting blood sugar. If it's overweight, please do lifestyle modifications because there's a chance you can develop diabetes in the future, right? And also, if you do develop, if you before the next pregnancy, make sure you go for preconception counseling to check yourself, because if you have diabetes, you need to control it before you conceive again, right? So those are the advices which you need to give the woman, right? If the woman had gestational diabetes during pregnancy. So what have we done? We have come the whole obstetric cycle. We have come from one to the other, and we have now come to the preconceptional clinic. Is that clear, children? So now we have principally completed gestational diabetes, which I wanted. These are the principles of management. Because I have not spoken to you about the finer points, but I wanted you to understand the principles of management of gestational diabetes. Next time we will do gynecology, and the time next we will do, or do you all want me to do pre-existing diabetes next time? Yeah, shall we do pre-existing diabetes and then complete that topic? And then at the same time, since it's a bit late now, I will take, because pre-existing diabetes, I only have to little to add on to what I just said, because the principles I have laid on everything. And then I will take all the questions. I have about 10-15 questions sent to me by the students. I will take the diabetes questions next time, because the pre-existing diabetes, the discussion will be short, and then we'll go on to questions and finish everything off at one time. Okay, is that good?
Yes,
right,
sir.
Okay, now I will open the forum to questions, right? You all can ask questions from me. I will give you all 10 minutes because I'm going to take the questions the next time because it's a bit late now. Right, let me just one question which I will answer. When starting insulin, do we stop metformin? No. Why is that? Because we are trying to achieve control. So with medical nutritional therapy, we have achieved a bit of control. That became not enough. Then we added on metformin, right? Even when going to the maximum, then it's still not enough. And then only on top of that, we have to add the insulin, depending on the blood sugar series. Is that clear? So we don't stop metformin. However, remember, there are instances you are not going to go near metformin. You are going to start insulin straight off. That is nutrition therapy and insulin, which we discussed already. Okay? Right. That is one question that is only there. So now the rest can just ask the questions for 5 minutes if you all want to ask me questions.
Hello, sir.
Yes, okay.
Yes, sir. I wanted to ask, sir, at 24 to 28 weeks, we directly go for a diagnostic test in all women.
Yeah, universal testing. It's called
Right.
universal screening. Yeah.
Okay, sir. A diagnostic test, not a
Sorry.
screening test.
Yeah. So you do a universal diagnostic test for all pregnant women between 24 and 28 without doing any screening test. Yes, correct.
Right, sir. And could hypothermia, neonatal hypothermia, be a complication?
Yes. The baby can have all the problems under the sun, right? Diabetic, the problem is most of them are large, right? And therefore their blood, as I told you, every organ is hypoxic, including their skin. Okay, so and the surface area is large, and therefore hypothermia is commoner in babies born to mothers who have diabetes. So therefore, yes, it's very important to keep the baby warm. However, that is pediatrics.
Thank you, sir.
All right, they will kill me.
Is there a higher upper limit of a dose of metformin per? Now we have a 2.5 to 3 gram per day dose. So when we take one dose, is there an upper limit like?
No, you can vary. You can do 500, 1,500 and 500, right? You can do 500, 1,000 and 1,000. So there's no real upper limit, right? But usually it doesn't come like that, because what happens is you always start with 500, 500, 500. So therefore, there's always a minimum dose left somewhere. And also remember, when you're treating a blood sugar series with insulin, it's always best to add the minimum possible dose, even if the your blood sugar series indicates that particular value to be normal. So I normally add 4 units because that is the minimum dose that you can give. For example, if the blood sugar series says 98 fasting, 120 post breakfast, 140 post lunch, and 160 post dinner, officially, if you think about it, you should not be adding any insulin to your 120, which is post breakfast. But I, as a practice to have uniformity, I always add 4 units to that. So I do 4, then 6 units, right? Post lunch, I said 160, right? Or 150, okay, 5 units. If it is 160 post dinner, 160, that is 6 units. And overnight, if it is 98, it's more than 95, then I will add 4 or 6 units in the night. Do you understand? So it's variable. There are no hard and fast rules, but that is what I usually practice. But officially, you can go without adding post breakfast because that is normal. Logically, you understand? You add only to the values that are higher for insulin. Okay, right? The few questions come in. People are very busy typing now. Can you please explain night dose of insulin again? Right. All right. That basically it's very empirical. You just add something depending on your experience. For example, for about say 100 fasting, I would add about, because it is 5 milligrams per deciliter over our intended value, right? Our ideal value. So therefore, probably I will add about 4 to 6 units of long acting. If it becomes 105, 110, 115, maybe I will add about 8 or 10 and see. We'll do a blood sugar series in 3 days, and if it is not there, I will increase it again. Right? Do you understand? There are no where you can calculate and add. No, that is just. Can a woman develop GDM in 3rd trimester after having normal at 28? Yes, they can develop gestational diabetes, and it depends on the amount of HPL and when the mother's relative deficiency starts to occur, right? And therefore, yes. When that happens, it is usually best to start insulin, right? Than to go through, because there's no time for us to go through MNT and then 2 weeks later, then metformin, and so it's better to add directly insulin to control your GDM. Is that only a long-acting insulin in the night? Yes, right? Usually, children for MBBS, just think of it as a long-acting isophane, right? Don't go for all these regimes because that is all this controversy. These are the ones we will question now postgraduates until they are blue in the face. Different regimes, different data, different trials. We love asking these poor people that, but not for MBBS students. Don't worry. Okay. Sir, do we have a neonatal team during delivery, even if there is no macrosomia detected ultrasonically, but just the mother is diagnosed with GDM and control is good or not? Yes. What is the reason is that even with without macrosomia, most of the babies, there's a portion of babies who develop shoulder dystocia because even without macrosomia. Actually, the most are like that. The reason is the ratio, it is thought, of the shoulders to the baby's head, because they seem to be having in babies with in diabetic mothers seems to be having a different ratio of the shoulder. They are larger, so therefore the shoulders might get stuck. Yes, if there's a woman with diabetes, whether the baby is macrosomic or non-ultrasonically, you have a neonatal team there. Okay. How often do we have a monitor fetus for macrosomia and polyhydramnios? Usually intensive monitoring children. How often do we have a monitor fetus for macrosomia and polyhydramnios? All right, this is during antenatal period. Once we discover macrosomia, remember, by our scans or by we will find a difference only after 2 to 3 weeks. Even weekly monitoring is not enough for macrosomia itself. Every 2 to 3 weeks you can monitor for macrosomia. Polyhydramnios, it all depends on the clinical discomfort in the mother, because polyhydramnios itself is not going to cause much problems for the fetus, because it's just the patient is just the baby is just urinating. Okay, But however, the mother may feel the discomfort. So as often as required, but usually 2 to 3 weeks gap between scans would be more than adequate. Okay. If mother is diagnosed diabetes at booking visit, can we take it as GDMs? No. So that is pre-existing diabetes, which is the topic for next week, children. Okay. Do we do neonatal blood sugar value as a must if mother got? Yes. As soon as the baby is born, the first thing the pediatricians will do is to do a blood glucose. Right? Why? Because as soon as the cord is cut off, nothing is coming into the baby, and the baby is not suckling well, and initially there's only cholesterol, right? So, and therefore the baby can become quickly hypoglycemic because the insulin production in the baby's pancreas is very high. And therefore, yes, definitely that is one of the things the neonatologist will do immediately, right? Is monitor blood glucose in the baby. So that is all the questions that are typed in. Any other questions? No? Right. So, right. So that's then concludes our session for today. So then next time I will do pre-existing diabetes, right? Which will have different. Now there's another question. Somebody has been busy typing. Okay, let me just do that as well. If the presentation is recurrent maternal infection as the presentation, should we consider it as an indication? Hold on. Okay. It's traveling up because a lot of people are typing now. The presentation is recurrent maternal infection as the presentation. Should we consider it as an indication for direct insulin therapy? Not really, because it may be due to other reasons as well. So it is not a direct indication for insulin therapy. You can go with your conventional sort of thing, but you need to treat the infection with the proper antibiotics if necessary. Right.
Sir,
Yes.
what are the trials that the postgraduates should read on diabetes?
That one once I do when I do your postgraduate lecture, which I'm doing 2 weekly. Not yet. No, I'm not doing obstetrics. But anyway, what you should look. Basically, child, go and look at the FIGO guidelines, the NICE guidelines, right? The WHO guidelines and the college guidelines. Each of them will have at the end quotations as to how they base their recommendations for cutoff values of OGTT. That is the diagnosis, the treatment, right? And the OGTT values and the discussion. So each of those guidelines, the best is to go to guidelines and look at the references, child. And there you will find all the trials which you want as well, right? Mainly it is the, there's a collaborative groups trials. They are basing a lot of on their trials. The HAPO, which is 2008 NEGM, that is then the Indian, you need to look at the DIPSI trial because that gives the WHO has recommended 1.5 MOMs and for the cutoff values for patients who are Asian and with small pelvises. Okay, that gives us the cutoff. Second hour cutoff value was not 153 but 140, right? So which is something that we need to consider when we are thinking about our Asian women. So all these are postgraduate, right? So that is the way you need to find your trials. Okay, and that is the way we'll be questioning you. Okay.
Sir, one more question about aspirin. Sir, is aspirin given?
One moment, I have a question. I'll answer. If diagnosed during pregnancy first time, is GDM, isn't it even a booking? I'm sorry, I don't understand. If diagnosed during pregnancy first time, is GDM, isn't it even in a booking? I don't understand the question, but however, what you have to understand is by definition, if diagnosed first time in pregnancy, it still remains as gestational diabetes. You change your diagnosis only 6 weeks after the patient has delivered. However, what you have to understand is, yes, we can have very healthy suspicions as to whether it is pre-existing or not. Especially if it's diagnosed during the first trimester, then most probably it is pre-existing. However, we do not make a diagnosis at that point, we do it later. Okay. Sorry, somebody said something.
Yes, about aspirin.
Oh, yeah. Aspirin, no, not indicated child. Now, aspirin to work actually, all right, for aspirin to work, what does aspirin do? If there is a problem with trophoblastic invasion in the first wave and the second wave, which happens very early, okay, right? If we start aspirin before that, it becomes helpful because the trophoblastic, there is some, it helps the trophoblastic invasion to become better. Okay, so that is how aspirin helps. So in gestational diabetes, pure gestational diabetes, we diagnose it late, right, after 24. However, there is a case for starting aspirin if we have very high values definitely in the first trimester, or if we are starting, if you are suspecting that it is pre-existing diabetes, yes, you understand. But routinely, this discussion does not come in gestational diabetes. Okay, right.
Thank you, sir.
Anything else? Okay. Either I have answered all your questions or you all are feeling sleepy. Right. Okay. Okay then. Then next week we will do pre-existing diabetes, right? And then the questions. Okay. If any of you all have questions, please type it into the what is this the group, and please invite all your friends, whoever wants to join. This is a free discussion, free event. Anybody, any graduate who is doing MBBS are welcome to just come in. Okay. Okay then. Good night.
Thank you, sir.
Thank you, sir. Good night.
Thank you, sir.
Thank you,
Thank you,
sir.
sir.